Good afternoon and welcome to the monthly webinar series of the Center for eHealth Information Adoption and Exchange with the Patient-Centered Primary Care Collaborative. This is Jeff Hansen. I'm one of the co-chairs of the center and a vice president of the healthcare group of Thomson Reuters. We have these monthly webinars, as I say, every month. Our next one happens to be June the 9th, and we'll give you some information about that at the end of the session here today. Today, I'm really personally kind of excited about the topic and can't wait to hear from our guest speaker. We're going to be discussing the role of pharmacists in the patient-centered medical home, and particularly the pharmacist's role in using technology for medication management outside of the prescription process. I grew up in a family where my father was a pharmacist. I actually had his own pharmacy and for a period of time, as well as in the public health service, and I can remember him coming home and saying what a joy it was to be kind of considered a consultant to his patients that would come in to have their prescriptions filled that he knew around town. And I'm really thrilled about the whole idea of this energy around getting pharmacists more involved in the medical neighborhood and ensuring that health information technology facilitates that. I'm really pleased that we're joined today by Shelley Spiro. Shelley is director of the Pharmacy eHealth Information Technology Collaborative. And this collaborative is an organization of 9 national pharmacy associations and 3 associate members focused on assuring the meaningful use of standardized electronic health records that support safe, efficient, and effective medication use, continuity of care, and provide access to the patient care services of pharmacists with other members of the interdisciplinary patient care team. In addition, they're assuring the pharmacist's role of providing patient care services is integrated into the National Health Information Technology Interoperable Framework. Shelley is president and owner of Spiro Consulting, an industry consulting firm specializing in long-term and post-acute care pharmacy services and health information technology, including all aspects of HIT, e-prescribing, medication therapy management, reimbursement and technology standards development. Before opening her own consulting firm, she was a hospital, long-term care, and home health care pharmacy corporate senior director and consultant pharmacist. Shelley's active in National Pharmacy Association standards development organizations and is a leader in pharmacy HIT. She is immediate past president and chairman of the board of the American Society of Consultant Pharmacists, past co-chair of the, I'm not sure what that stands for, Shelley, maybe you can fill us in eventually, but the NCPDP Long-Term Care Work Group 14. Member of Pharmacist Services Technical Advisory Coalition, and several other organizations. So we are really pleased, and I'll turn the microphone over now to Shelley Spiro.
Thank you, Jeff. I appreciate that, and just want to thank Chris and Jeff for inviting me to this webinar today in order to speak with you. As Jeff has said, my name is Shelley Spiro, and I'm the director of the Pharmacy Health Information Technology Collaborative. And we're going to be talking about the medical neighborhood, HIT enablement of medication-related care coordination. The Pharmacy HIT Collaborative, or what I call the collaborative, was founded in September of 2010 by 9 of the National Pharmacy Professional Associations. Those associations were part of a JCPP, which is the Joint Commission for Pharmacy Practitioners, and health information technology is one of the areas that fell into their strategic plan, and one of the reasons why these 9 organizations formed the collaborative. The collaborative actually represents over 250,000 members in all practice settings. And the founding members of the collaborative are the American Association of Colleges of Pharmacy, or AACP, the American College of Clinical Pharmacy, the Accreditation Council for Pharmacy Education, the Academy of Managed Care Pharmacy, the American Pharmacist Association, the American Society of Consultant Pharmacists, the American Society of Health System Pharmacists, the National Alliance of State Pharmacy Associations, and also the National Community Pharmacists Association. In November of 2010, the collaborative was opened up to associate members because we are a collaborative that is an inclusive collaborative, not an exclusive collaborative. And we want to open up our collaborative to those who share our mission for the role of pharmacists in health information technology. We now have 3 associate members, SureScript, NCPDP, which is the National Council for Prescription Drug Programs, and Relay Health. The primary goal of why the collaborative actually exists is to assure that effective use of medications, especially the meaningful use of standardized electronic health records that support safe and efficient and effective medication use, continuity of care, and provides access to patient care services of pharmacists with other members of the interdisciplinary care team. Our other major focus is to ensure that the pharmacist's role in providing patient care services is integrated with our national HIT interoperable framework. Oh, went too far. Okay. The collaborative's primary goal in relationship to the patient-centered medical home is to ensure that the pharmacists provide patient care services, particularly as members of the interdisciplinary professional team supporting the PCMH, which is our patient-centered medical home, and also our accountable care organization structures, and that it's integrated from a technology standpoint. The mission of the collaborative is to do education and outreach. The education and outreach takes place inside the pharmacy sector. Also, pharmacists who are part of our 9 founding members, as part of those 250,000 members, faculty, which includes our colleges of pharmacy and the students that are learning to be pharmacists, and also pharmacy staff who are actually working in dispensing functions in pharmacies, such as Jeff has given his example of what his father had done throughout many years as being a community pharmacist. Also, we focus on education and outreach to ancillary organizations that are aligned with what pharmacists do. Those would be providers or vendors, networks, payers, researchers, and folks such as yourself who are on the call today. Also, outside of the pharmacy sector, we look to educate and do outreach with policymakers, healthcare providers, patients, and consumer organizations, and hopefully we're doing some of that outreach today on this webinar. I'm going to go back a slide, and Lauren, at this time I think we have some polling questions, some questions that we'd like to ask our audience to give us some ideas of who we're speaking to today. So, Lauren, do you want to begin the polling? Our first polling question is, does your medical home currently encompass pharmacist/pharmacy support? Please answer the question, yes, no, not yet, a medical home, or not applicable.
The results are rolling in here. They'll be on the screen in a moment.
Thank you, Lauren. Excellent results. Looks like we have 26% that say yes, 13% say no, 17% not yet in the medical home, and 45% is non-applicable. We thank you for that, and I think we have another polling question.
I don't believe that we do at this point. Okay. That's the one.
And we will go back to our slides. Great. Part of the PCPCC's medication management work group, there was a resource guide, and it was titled Integrating Comprehensive Medication Management to Optimize Patient Outcomes. I put the link on the slides, and I encourage everyone to go to this document. It's an excellent document that really outlines the medication management portions of what pharmacists need to do and be involved with, and really what all of us need to do who are involved in the medical home situation, and including our medical neighborhood. There's great information, and I encourage you to look at it, and I'll be talking a little bit about some of that information throughout the slide deck in this presentation. Just as a little bit of overview of part of this, there are more than 3.5 billion prescriptions that are written annually in the United States. 4 out of 5 patients who visit a physician leave with at least one prescription. And medications are involved in 80% of all treatment and impact every aspect of a patient's life. These are facts that are out there, and it's only going to be growing as our patients hit the age of 65 and older and are living longer. With the baby boomer population starting in this year, actually, January 1st, 2011, we're going to be seeing much more patients on medications and having the need to have a medical neighborhood available to them. Within this document, the document outlines 10 steps to achieve comprehensive medication management. These are very important 10 steps, not just for pharmacists who are providing services for medication management, but all providers of care related to medication. First, we need to identify patients that have not achieved clinical goals of therapy. Second, understand the patient's personal medication experience, history, and preference of release. Third, to identify actual use patterns of all medications. This includes over-the-counters, bioactive supplements, nutritional products, and prescription medication. Our patients take a wide range of different types of medication, and the role of the pharmacist is really to make sure that we can get that information to our patients and make sure that we can document what those patients are on. We found through some research of pharmacists are very effective in getting patients to open up about their medications and what medications they're taking. The fourth step is to assess each medication in the following order for appropriateness, effectiveness, safety, which includes drug interactions, and adherence focused on achievement of clinical goals for each therapy. Our fifth is to identify all drug therapy problems, the gap between current therapy and that needed to achieve optimal clinical outcomes. Our sixth step is to develop a care plan addressing recommended steps, including therapeutic changes needed to achieve optimal outcomes. Patients agree, and our seventh step is for the patients agree with and understand the care plan, which is communicated to the prescriber, provider of his or her consent and support. This is really one of the most important areas. If we're going to be successful in making sure that we're optimizing medication management, we have to include the patient. And that's why the patient-centered medical home is such an important aspect of what we do as pharmacists, and can be very effective in the care that we're providing to our patients. The eighth is to document all steps and current clinical status versus goals of therapy. Our ninth step is to follow up evaluation with the patients are critical to determine effects of changes, reassess actual outcomes, and recommend further therapeutic changes to achieve desired clinical goals and outcomes. Our 10th step is a comprehensive medical management. It is a reiterative process. Care is coordination with other team members, and personalized patient-unique goals of therapy are understood by all team members. This is the most important and probably the focus of what we see in a patient-centered medical home, is that we work as a team together to make sure that as that team that we are looking at our patient-centered aspects of their medication therapy. Pharmacists play a very important role in that and work very closely in an interprofessional team approach with other healthcare professionals for the benefits of our patients and the quality of care they receive, especially with medication therapy. The next slide is a pictorial of what I envision as our medical neighborhood. Of course, we have patient-centered medical home, and we have primary care physicians and care coordinators. We also have pharmacists providing that patient care services, such as medication therapy management and medication reconciliation. It's very important from a technology standpoint that we all work together to exchange information related to our patients in order to be successful. This includes information from the pharmacy at the prescription dispensing and also immunization. The prescriptions we are able to exchange quite readily with many of the initiatives that have taken place in electronic prescribing. And we're working with other methods to make sure that we can communicate the information coming from the pharmacy that's dispensing the prescription to our patients in their medical home. Also, there are many pharmacists throughout the United States in community settings that are the #1 immunizers of, as an example, flu vaccine, and play a very important role in the pandemic situations that can occur with our patients who might need immunization. We need to be able to communicate that information and exchange that information with primary care providers. And nowhere is that more important than in the medical home. Also, hospital discharge summaries and medication reconciliation is a very important part. And to assure that the pharmacists can exchange information in those settings, we work very closely in the collaborative to assure that our pharmacists in the hospital setting who are seeing that patient for that episode of care are able to communicate that discharge information related to medications and the medications that they reconcile to the new care provider at the transition of care. Pharmacists and laboratory information is extremely important. As pharmacists, if we're going to be evaluating the medications, we need to understand the laboratory results that have taken place. There are many medications that are out there that require a therapeutic drug index, a very narrow therapeutic drug index, that can be very critical, so the dosing is very important. Many of our pharmacists work very closely in evaluating laboratory information to assure that medications are appropriately taken. Most important, we need to make sure that our patients, through their personal health record, once they obtain an electronic personal health record, are able to receive this information and we're able to have access to it and make recommendations for their care, be part of the care. And that's the big message that we have within the medical home model. Let's go on to our next slide, which is, this slide represents the meaningful use of the electronic health record. The Centers for Medicare and Medicaid Services have provided incentives for eligible professionals and eligible hospitals that went into effect January 1st, 2011. Many of the early adopters are part of the meaningful use of the electronic health record in the processes. And there are 3 stages that are set to make sure that the meaningful use of the electronic health record takes place. As pharmacists and part of the mission of the collaborative, we work very closely with the standards development organizations to create a pharmacist electronic health record using the same functional profile that other healthcare professionals would use. And we mapped our pharmacist electronic health record after the physician in the ambulatory setting. One of the areas with the meaningful use of the electronic health record and the CMS incentives actually use measurement concepts to make sure that the providers that they're paying incentives for are actually using the electronic health record in a meaningful way. Some of those measurement goals are related to care coordination, including medication reconciliation, and patient safety, including adverse drug events. These are very important components of the meaningful use of the electronic health record and play a very important role in what we will do in our medical home. This is a pictorial that I like to use. It's a little complex, but it says a good message. On the left-hand side, it really goes into the different types of electronic health records that each type of practitioner might use in their own setting, including labs and pharmacy, radiology. That information is gathered in the form of electronic health record, goes through an electronic health record, which you could see in the middle of this pictorial, and then creates an overall electronic health record of information in what we call the form of the continuity of care document that will be shared with others who are doing care coordination. It's a much more simplistic model, especially as it relates to pharmacists. As I said before, through the collaborative, we worked on forming a pharmacist electronic health record that we use for exchanging information with other electronic health records. So in the center, in that red circle, is really where the pharmacist or pharmacy practice management system would sit. Just as if we were in a physician's office, a physician has a practice management system where they would record the care that they took of that patient. It's the same thing for pharmacies and pharmacists. We provide certain information and collect certain information on the patients that we see, not only dispensing medication, but also other patient-provided services. The next circle, which is the green circle, depicts really the pharmacist EHR. The information that comes out of the pharmacy practice management system is captured in the pharmacist electronic health record. That purple circle represents the health information exchanges, or e-prescribing networks, that will take that information in the form of a continuity of care document and exchange that information with other healthcare providers who have other electronic health records, such as our eligible professionals and our eligible hospitals that are receiving incentives from CMS for the meaningful use of the electronic health record. The pharmacist electronic health record also has the means, eventually, once all of the standards development organizations figure out how to populate the personal health record using the continuity of care record. You'll see the arrow, which goes both ways, because the important portion is to make sure that we're sharing the information in a bi-directional way. If we're going to be able to be successful, especially in our medical neighborhood, we have to be able to exchange the clinical information freely between electronic health records. Not just to push from an electronic health record, for an example, as a hospital that would push out a discharge summary, but that information has to come from, as an example, a community pharmacy or our medical home pharmacy or pharmacists that are actually sharing that information when the patient has to go back into the hospital to make sure that that hospital understands the medications and the therapies that that patient is on. Therefore, they'll be able to optimize the care of that patient when they're admitted into a hospital. This is true for any transition of care setting that we're looking at, whether it's hospice or home care or long-term care. The pharmacist electronic health record was developed to work in all practice settings. For those of you who might not be familiar with the Health Level 7 EHR functional profile, briefly I'll discuss the different sections of them. The HL7 EHR functional profile is broken out into 3 sections: direct care, supportive, and information infrastructure. To a system vendor, this explains what functionality that system has to include. What we propose with the collaborative, with the Pharmacy EHIT collaborative, is to work with our system vendors to help adopt the functionality of the pharmacist electronic health record. And we've defined the areas of direct care, support, and information infrastructure to help them do that. These include things around privacy and security, and to make sure that we're following the same type of criteria that any other meaningful user of electronic health record would use. This is an example of the functionality or the conformance criteria that is used in creating the pharmacist electronic health record. This is a section out of the direct care that goes into managed patient clinical measurement. This is the same functionality that is in the ambulatory functional profile. The pharmacist pharmacy provider EHR functional profile, PPEHR, as some of us have used that acronym, I call the pharmacist electronic health record. Went through the standards development definitions. It took us a few years to go through that process. We've gone through the standards development organization balloting in both HL7 and NCPDP, the National Council for Prescription Drug Programs. That balloting completed, actually, we finished our normative ballot, which is an international ballot for the pharmacist EHR that ended on May 7th and did pass through that ballot, and we'll go on for ANSI accreditation, American National Standards Institute accreditation. The collaborative will work closely with our system vendors and others to assure that we go through the National Institute for Standards and Technology's definition for certification criteria for the meaningful use of the electronic health record in relationship to the pharmacist electronic health record. We'll also work with the certification entities to make sure that the pharmacist EHR does go through that certification process. The collaborative will work closely with our system vendors for adopting the pharmacist EHR functionality into their practice management system, and to assure that the pharmacists use that certified electronic health record. And as a collaborative, especially with our 9 founding members and our associate members, are in a perfect position to help with that adoption and getting that word out of the value of making sure that pharmacists have the ability to build the information that will be exchanged with others in our medical home. We're also working to share our electronic health record. After the adoption, leads to the pharmacist to share the electronic health record information with other members of the interdisciplinary team. This is one of the reasons why that electronic health record is so important for pharmacists, because we'll be in the same position as others to make sure that we can be meaningful users of the electronic health record and exchange that clinical information. Also, pharmacists who are providing this patient care services that will be able to demonstrate the value that improves that quality of care, especially for the meaningful use of the electronic health record. The other effort that the collaborative is working on is creating a value set for medication management. We've been working very closely with the National Library of Medicine to actually create a situation where we are creating what we call SNOMED CT codes. SNOMED CT codes is a coding mechanism for clinical terminology. It is a systemized nomenclature of medicine. Clinical terms is the term for SNOMED CT. And we work very closely with the National Library of Medicine. We actually submitted 341 definitions related to medication therapy management. This will lead us to the creation of a value set. And the value set includes other codes such as ICD-9, ICD-10, which are diagnosis codes, CPT codes, which we do have clinical procedure terminology codes for medication therapy management. Other aspects of codes that will go into making sure that we've codified the documentation portion of what we do as pharmacists in providing patient care services, especially in the area related to our medical home. We've also provided a mechanism an ongoing mechanism to identify new codes and structures and definitions for codes where we currently don't have codes. So as an example, in our medical home, we might have a situation where there might be a medication management code that's needed for care coordination that hasn't been identified yet. We'll have the means for whoever would like to submit that type of code to take it to the National Library of Medicine all the way up to the international coding structure where SNOMED is held. If we're ever going to reach the meaningful use of the electronic health record, it's extremely important that we have ways to measure that we're meeting those goals of meaningful use of the electronic health record. In order for us to meet that meaningful use of electronic health record, the measurements have to have some type of value set attached to it so that we can quantify what we're doing. And that value set has to be codified in a way that's standardized that all providers would be able to use and understand. There are certain items that are necessary for comprehensive medication management. First is the patient's meds and experience record. This information came out of the PCPCC guide, a medication management work group, and out of their guide that I talked about in the beginning of our presentation. Also, medication allergies and adverse reactions, medication history, including immunization, current med record, active drug therapy problemless, therapeutic treatment plans shared with patients and practitioners. All of these are very important components in order to reach a comprehensive medication management. It's important that we're able to share this information electronically between all healthcare providers who are taking care of our patients in our medical neighborhood. Some of the most important information that needs to be shared from an HIT standpoint will be necessary for comprehensive medication management are to connect indications for medications, or basically the reasons for use, to identify, resolve, and prevent drug therapy problems, to assure appropriateness, effectiveness, and safety and adherence, to record and evaluate drug therapy outcomes, therapy, personalized therapy goals against each medical condition outcome, graph lab levels against drug changes, and record outcome changes in med details. Provide post-market surveillance on appropriateness, effectiveness, safety, and adherence variables. Also, more components of health information technology, to make sure that these components of health information technology in order to reach comprehensive medication management are also to record drug therapy problems specific to the drug product, medical conditions, and patient parameters. Offer clinical decision support and analysis. A very important aspect of what we do in the medical home is to make sure that other healthcare providers can follow clinical decision support that has been overseen by pharmacists to assure that we're going to maximize the medication outcome. We're going to support patient participation and decision-making in drug therapy. A huge aspect of what is the value of health information technology is to really bring the patient into the process and to give them the correct tools, to give them good tools that they'll be able to manage their medications on their own. Provide patients with individualized medication information that complements their therapeutic care plan. We can create all the care plans we want, but if we don't have the right tools to help our patients understand that care plan, they'll never be successful. So technology can really help with this particular portion, where we can teach our patients from a technology standpoint to understand their medication action plan and their care plans related to the medications that they're taking. Provide a website for the patients to participate in managing their meds. Some of the pharmacist's activities in interprofessional patient care, electronic prescribing is a very, very important component of what we do. It's important from a patient safety standpoint that prescribers can communicate electronically the prescription that they're trying to fill for that particular, or they want filled for that particular patient. And it's important for those pharmacists to send information back to the prescribers when there's problems that they've identified with that patient, whether it's a drug interaction or whether that's a potential problem that the pharmacist might know because that patient is taking an over-the-counter item or a homeopathic type of medication that that prescriber might not have known, or that patient care team might have not known in that medical home model. Pharmacist and the pharmacy provider EHR functional profile, or a pharmacist EHR, is another important component to make sure that we can work in an interprofessional patient care mode in relationship to health information technology. Making sure that the information is bi-directional exchange of the clinical information is very important if we're going to meet the meaningful use of the EHR measurement goals. As I stated before, immunizations are a very important function of what we do as pharmacists in many of our community settings, where we are, in some cases, the #1 immunizers of flu vaccines in certain areas of the United States. This information has to be communicated with our patients in our medical neighborhood. Patient care services. This includes our 10 steps to achieve comprehensive medication management. In addition, medication reconciliation and transition of care is extremely important, where we need to make sure we're bringing in our other care settings who might be taking care of that patient for an episode of care. And then when they go back to their home, they're able to share that information and make sure that we're reconciling those medications to optimize medication therapy. Quality care and outcomes performance measures. In the creation of the MTM value set, we'll have codified means, standardized codified means to begin to measure the quality and outcomes of the care that we've provided to our patients related to the medication services that are being provided. The majority of our pharmacists, especially in the community setting, have created 5 steps that are very important for medication therapy, for the medication therapy management process. We call these core principles, or the basic core elements of medication therapy management. They include medication therapy review, personal medications, medication-related action plan, intervention or referral, documentation and follow-up, which reaches optimized medication therapy. Many of the medication therapy management processes are occurring today. These occur in the Centers for Medicare and Medicaid Services, the Medicare Part D program. Medication therapy management is one of the programs that is in and available for the beneficiaries who are Medicare eligible. In the medical home, the patient-centered medical home, we have to take our medication therapy management a little bit further in order to be successful. And that's where we follow these 10 steps to achieve comprehensive medication management. It takes our core elements of MTM and takes it just a little bit further because of the special needs that we see for our patients in the medical home. This is to identify patients not achieving clinical goals, patients' personalized med history experience, identify all med patterns, access each med, identify all drug therapy problems. Our 6th step, develop a care plan. 7th step, patient agrees and understands the care plan. One of the most important pieces to have a successful optimization of medication therapy, when we can get the buy-in of our patient to understand their medication therapy, we've been very, very successful in proving successful outcomes and quality of care of our patients, keeping them in their medical neighborhood. Document steps versus therapy goals, follow-up evaluation, and most importantly, the goals are understood by all team members. This is the focal point of the patient-centered medical home, and that is for all of us to work together as team members to make sure that we're meeting the goals of our patients. No more important is that than in medication management. This is a slide I've used often to really talk about cultural diffusion of health information technology. We're at the adoption stage. Many of us are early adopters of health information technology, and adoption is just a piece of what we need to do. We need to be able to use our electronic health records in a meaningful way. We need to use all health information technology in a meaningful way. But most importantly, to be successful, we have to fully integrate that into our workflow processes. We have to fully integrate the meaningful use of the electronic health record in what we do day to day. We shouldn't have to stop what we're doing in our process to document or to provide information. That should be part of the workflow process. And our system vendors want us to achieve that goal. But as users of health information technology, that's where we come in, where we have to take that process and work it into our everyday workflow. To not let the health information technology drive our actions as providers, but to use health information technology as a tool. Nowhere more important is that than in medication management. The Pharmacy EHIT Collaborative works with many organizations. We work with organizations from a policy standpoint with Health and Human Services, Centers for Medicare and Medicaid Services, and the Office of the National Coordinator for Health Information Technology. We also work very closely with standards development organizations, as we have shown in developing the pharmacist electronic health record, and other aspects and transactions to make sure that pharmacists providing patient care services, those services and clinical information can be exchanged with other healthcare providers in the standard process. We work very closely in creating a value set, especially for medication therapy management, that have the means to grow that value set for all care practices to make sure that our patients' care can be evaluated for the outcomes and the quality of care outcomes that we're providing as pharmacists. We work closely with the quality organizations, such as the Pharmacy Quality Alliance and the National Quality Forum, to assure that the quality parameters that are being placed, especially for the meaningful use of the electronic health record and medication therapy management, are integrated into the health information technology infrastructure. Most importantly, such as what we're doing with this webinar today, is working in the patient-centered medical home and working with our accountable care organizations to show the value of pharmacists and assure that the pharmacists have an active role in the exchange of clinical information, and make sure that pharmacists can exchange that information in the medical home. Is going to be a very important function for all of us to achieve these initiatives. And with that, I will turn this back over to Chris or Jeff for questions and answers.
Thanks, Shelley. I guess Chris might not be on, or this is Jeff. So I want to open it up for questions and answers. If Lauren, if you're still on, do you want people to write the questions in, or are they free, or the phone lines are open?
No, they can just put their question in the question box. It should appear on the control panel. We already have 4 or 5 lined up. Chris, are you with us?
Yeah, hi, I'm back. I was having trouble unmuting myself. Hi, everyone, and thank you, Shelley, for a very inspirational high-level overview of really what's at stake for actively integrating pharmacy services into the medical home. And we do have a couple of questions, and the people do have an opportunity to continue to enter them in the question box, and I'll start out with the first one. Do you coordinate with home health agencies, SNFs, nursing homes, and LTAC? Yes, I'm not sure what some of the acronyms are.
Well, I can help with the acronyms.
Okay.
My background is definitely in the long-term and post-acute care, which is LTPAC, but LTAC, which is the long-term acute care hospitals, which is really LTAC, where we see much of the rehab situation. Home health agency, absolutely. These are very important focal points. The role of the Pharmacy EHIT Collaborative, the mission of the Pharmacy EHIT Collaborative, is to help define the role of the pharmacist in all of those practice settings to assure that we can optimize medication management. It's very important, and probably moreover than anywhere else, we see this in the patient-centered medical home. But it doesn't matter where that patient resides. We have to be able to follow that patient through longitudinally through their care. And none of that is more important than what we see happening in our long-term and post-acute care settings, our hospice, home care, long-term care, which would include skilled nursing facilities, rehab hospitals, or long-term acute care hospitals. Even the hospitals for that episodic care where that patient is. We have to be able, from an HIT standpoint, to actually exchange information with all of those settings. And we do this through the standards development work. This is one of the reasons why we developed the pharmacist electronic health record, so that we would be able to create the information of the patient care services provided by pharmacists would be able to exchange with another electronic health record.
Great, thank you. You had a slide that spoke of measurements for meaningful use of the electronic health record, and this is certainly an area that a lot of stakeholders are grappling with right now. And then you segued into a slide that talked about documenting compliance with medication management aspects. Are you suggesting that that's a metric that could be used to document meaningful use, or could you give us a glimpse of some other ideas you're looking at for metrics?
The Pharmacist EHIT Collaborative has an advisory work group of 37 pharmacists and ancillary individuals who, from our collaborative members, who are leaders in this particular area. And we've reviewed the meaningful use of the electronic health record measurement concept and feel very strongly that pharmacists fit very nicely into those measurement concepts. We touch on every single area, including electronic prescribing, computerized physician order entry, medication reconciliation, making sure that drug interactions are taking place, allergies are being recorded and exchanged. So the pharmacist electronic health record will work very easily, no matter what practice setting. The quality measures that are being worked on nationally through the meaningful use of the electronic health record for eligible professionals and eligible hospitals will fit very nicely into what pharmacists do, no matter what practice setting they're in. And many of our pharmacists are in those practice settings. We have pharmacists today who work in the hospital settings and work very closely with meeting those meaningful use of the electronic health record measurement concepts for the hospital setting. We have pharmacists who are part of physician practices, including some pharmacists who are part of our patient-centered medical home practices and care coordination, who are part of the meaningful use of the electronic health record. Medications are a big portion of the meaningful use of the electronic health record. So we're really not supporting any other quality measures other than defining and providing a value set for a standardized method for documenting the quality measures. The development of the SNOMED CT codes through the National Library of Medicine is something that other healthcare providers are looking at to continue with that documentation of the meaningful use of the electronic health record.
Great, thank you. The next question is whether the PCPCC group on HIE, and I guess the questioner is asking about this particular group, the Center for Health Information Adoption Exchange, have we been working with or incorporating these directions and guidelines into our programs? And I think I can comment on that. We started a dialogue with Shelley and our organization a couple of months ago, and this webinar is one of the first steps along the path to finding other areas where we can support each other's endeavors. So stay tuned. We're on the road to looking for ways to leverage each other's efforts.
And if I can
yeah,
add
please. Yeah.
We appreciate the efforts. The pharmacist's role in the medical home is a very, very important role to the collaborative, and anything that we can do to assure that that takes place, we're right there with you.
Great, thanks, Shelley. Someone contacted your organization, Shelley, to find out how to approach their local pharmacists or large or small pharmacies to participate in their lone local medical home projects connected by HIEs?
Being the Pharmacy EHIT Collaborative, 9 of our founding members are the National Pharmacy Association. So they certainly can contact us through our website, or they can contact each of the individual organizations, which we have linked onto our website, which is www.pharmacy-hit.org. All of the, especially the American Pharmacists Association, the National Community Pharmacists Association, the American Society of Consultant Pharmacists, the American Society of Health System Pharmacists, NASPA at the state level, which is the National Alliance of State Pharmacy Associations, work more on that state and local level to really connect with the state pharmacy associations. So they would be a good place to start. So if it's more of a national initiative, certainly go to the national level. But if it's more on the state level, you might want to check with a NASPA or your state pharmacy associations, which might help you.
Great, thanks. The next question has some interesting aspects to it. Please discuss the role of patient consent in the attempt to reconcile medications across care settings.
I think that is not unique to pharmacy, or to pharmacists. I think that's what we all have to deal with. If we're going to work as an interdisciplinary team, especially in the medical home, we have to make sure that up front that we help our patients understand the value of the services we're providing. Medication is a portion of their care. It's not a separate piece of their care. And that's the message that we really have to give to our patients. It's a whole concept that they have to be part of. Medications play a very important role in that. And as we work as a team member, that consent they'll understand the need for that consent. Because we all of us who are providers of patient care, from physicians to nurses to pharmacists to the lab, to all aspects of what we're doing with that patient. I hope I didn't exclude anyone. That we all need to work with our patients together, and medication is a portion of that. When we get our patients to understand that, that consent won't even be needed, because they'll understand the reasons for all of us to be involved in their medication therapy.
Great. The next question has several parts, so let me try to combine a couple of them I think may be answerable in the single answer, and we'll separate out the third. How well you feel the current pharmacy workforce is prepared to meet the needs that you've described in this webinar, or otherwise what interventions are needed to assure appropriate training and ongoing certification to play this key role?
That's a great question. I can assure you that our pharmacists who are coming out of our universities are extremely, I would say, over-prepared. They come out with a doctor of pharmacy, are very, very well prepared in medication therapy management, the 10 steps of comprehensive medication management. Our pharmacists who are currently in their practices have very extensive knowledge of medication management. Unfortunately, many of our pharmacists are underutilized in their knowledge and care for those patients, mostly because of reimbursement issues related to being reimbursed for the product of the dispensing portion and not necessarily the provided care services that pharmacists provide. I think as we move towards an accountable care model or a managed care model, that we'll be able to make sure that the pharmacists who are trained for medication therapy management are able to take care of the patients and move rather quickly into those models. I believe that that we do have certain extra certifications that pharmacists can go through, whether that's through a geriatric certification program, which we do through the American Society of Consultant Pharmacists, to board certification through ACCP and some of the other organizations. There are many aspects of credentialing that we do as pharmacists, just like any other profession does. So we do have specialists in certain areas, such as geriatrics and pediatrics and pharmacotherapy, oncology, but all of our pharmacists are basically trained throughout their academic years as really understanding medication therapy management.
Great. What changes do you think need to occur to assure physician-pharmacist trust in this new setting?
Well, I have a very optimistic view of the world. You probably have noticed. And I feel we already are working towards that. And we just need to continue to work in that aspect. I think as physicians, and we have many, many areas throughout the United States, including in our public health services and our Indian health services, where pharmacists are an integral part of that interdisciplinary team. And we need to just continue to push towards those settings where pharmacists work very closely with our physicians to assure that we're maximizing and optimizing the medication therapy of our patients. I know that there are settings all over the United States such as this in pockets, and the medical home and our medical neighborhood is a perfect opportunity for all of us to work together for the benefit of our patients. We have so much to do in the care of our patients. Technology is will be so much a part of what we're doing that we need to be able to work together, and that's why patient-centered focused is the way to go. And if we all focus on taking care of our patients, we'll begin to work together for that focus. And I have to applaud PCPCC for that work, because they've really done a great job in bringing that message forward.
Great, thanks. What companies are currently using the standards you mentioned to develop pharmacist EHRs, and otherwise when should we expect to have pharmacist EHRs on the market?
Well, there are pharmacist EHRs on the market today. They just don't follow the standards. So because the standard is fairly new and has just finished the balloting process, we're working very closely with our system vendors to adopt the functionality into their current electronic health records. You look at any hospital system, it has components of that functionality in it today, but most of that's in a proprietary process. So we're working closely with our system vendors to adopt the functionality, knowing that the pharmacist EHR is not a system itself. All it does is define the functionality for the system vendors to adopt that functionality and then go through the certification process so that they can certify that they're actually following the standards. By doing that, that will allow them to exchange clinical information with another electronic health record that has gone through that certification process also.
There's currently a government stimulus for adoption of meaningfully used EMRs for hospitals and physicians' offices. Do the pharmacy EHRs receive the same benefit now? And do you know of any effort to secure any funding for pharmacy-specific EHRs?
Unfortunately, no. The pharmacist electronic health record is not receiving incentives from CMS for the adoption of the meaningful use of the electronic health record, nor are many other organizations or entities such as behavioral health or the long-term and post-acute care setting. So pharmacists are not alone in that aspect. We work very closely, the Pharmacy HIT Collaborative works very closely in conjunction with CMS and the Office of the National Coordinator for HIT ONC to show the value of the pharmacist electronic health record in this process. The incentive programs are led through legislative efforts on the national level. There is a limited amount of funding that's related to that. All that aside, still, it's important for us as a healthcare professional to look past the incentives and to try to focus on what's going to be right for all of us to meet the meaningful use of electronic health record objectives. The reason we're doing that is really to help our patients and to provide good quality of care. And so hopefully the government and others will recognize that these incentives need to be extended to other healthcare professionals, including pharmacists who are using a pharmacist electronic health record, but also to other organizations so that we can work together to make sure we're taking care of our patients.
Great. As a follow-on to a couple of the previous questions, what agency will certify the pharmacist DHRs?
The pharmacist DHR will go through the certification process, and there's 3 certification entities right now that are recognized by CMS for the meaningful use of EHR, and that is CCHIT, which is the Commission for Certification of Health Information Technology, the Drummond Group, and also InfoGuard are 3 that are recognized. Now, there might be others. The Pharmacy EHIT Collaborative doesn't distinguish which of our system vendors would go to which of the entities. We just work with all of them to make sure that all of the certification entities to make sure that the pharmacist DHR performance or certification criteria is identified for the meaningful use of the electronic health record. So we'll support all of our system vendors who want to go through any of the recognized certification organizations in that work.
Great. Pharmacists are currently reimbursed through dispensing, retail sales, and recently MTM. It's another acronym I don't need help with. What is the likely reimbursement model for a pharmacist who takes the time to help provide comprehensive care management for a patient?
That's a great question, and MTM is medication therapy management, by the way.
Great, thank you.
You're absolutely right. In our current fee-for-service model, prescriptions are no different, and pharmacists, especially in the community setting, are compensated for their clinical services through the dispensing of the medication. Now, this is not a sustainable model for the type of care that needs to take place with our patients. Automation and other aspects are coming into play for our pharmacists, for the prescription processing portion. Pharmacists, though, and the role of the pharmacist in patient care services is an area that is much more preventive care rather than providing a fee-for-service type of process. So as we move towards an accountable care organization or managed care, then those services are reimbursed based off of the overall outcomes, or if you would look at it as an example, payments for performance model. And pharmacists will begin to change their reimbursement model to match that payment for performance model, and will be very successful in the accountable care organization type of model. We see this today in areas such as managed care models, large health systems, where pharmacists who are in more of that clinical role are a very valuable portion of a part of that interdisciplinary team. We also see this in the public health services and Indian health services, Veterans Administration, where pharmacists are a key player in the medication management portion of what's taking place. So I think as the United States moves more towards that payment for performance model and moves away from a fee-for-service model, we'll be able to see that change in reimbursement and really pay pharmacists appropriately for the services that they're providing.
We still have time for a couple more questions if people want to enter them into the text box there. There's been a request to repeat your website for your organization, Shelley.
Certainly. It is pharmacy, it's www.pharmacy-hit.org.
Great. And as a reminder, today's presentation and slides will be available at the end of the day on the pcpcc.net website. And Lauren, if you could confirm the URL that people should go to, that would be great.
It's either on the Center for eHealth page, pcpcc.net/media, or on the homepage itself.
Great, thank you. We have another question, Shelley. Do you have any strong evidence for a return on investment on these pharmacy EHRs?
Unfortunately, I don't have any information on return on investment other than the value that pharmacists provide provide today. And we have many research processes and demonstrations that have taken place really showing the value of pharmacists in an interdisciplinary team. We don't have a lot of research that really identifies that use of health information technology and the exchange of that information with other healthcare providers. We're hoping that as pharmacists who are involved in the patient-centered medical home and in our medical neighborhoods, who will begin to use technology and will begin to adopt the pharmacist DHR, will be able to collect some of that information. Knowing that we now will have very shortly, the means to have our SNOMED, the MTM SNOMED CT codes available to help us with that documentation to show value, we'll then be able to measure the return on investment for the adoption of the electronic health record for pharmacists.
Very good, thank you. We have one more question coming in, comment perhaps. The PCPCC has presented great data on organizations that have integrated pharmacy into the PCMH that show impressive ROI. We don't need to reinvent the wheel, so yeah, thank you for the comment.
There you go.
All right. Jeff, I guess I'll turn it back to you for closing comments.
Thanks, Chris, and thanks, Shelley, very much. I think it was an excellent presentation, and we had well over 100 people on, so I know you'll probably be getting a lot of follow-up. It's an area that I think a lot of people have an interest in. At this point, unless there are other comments or questions coming in from the audience, I'd like to remind everybody that our next webinar is on June 9th at 1 o'clock in the afternoon, Eastern Time, and that'll feature Christine Zarkadoulis from Mount Sinai Medical Center and Sylvia Chow from NCI. They'll be speaking about the health literacy and usability issues with personal health records. So it sounds like another great session. We hope you tune in and let other people know about these webinars. And if you have any more interest in the center or some of the other centers at PCPCC, don't forget to log on to our website at pcpcc.net. So without further ado, I want to thank Chris and Lauren and Shelley and for a great session today. Thank you.
Thank you, Chris.
Thanks.